Fantastic. So we're on. I want to welcome those who are with us today on our webinar. This represents the very first of our series of colloquia designed to showcase the wonderful professional projects done by our PCLP scholars, our inaugural group of scholars, which we're very excited to talk about over these next couple of weeks. I'm Melinda Flynn. I am the consultant who's been working with our wonderful group of faculty advisors and other projects here, along with the NMF and PCLP staff. Today we're going to be talking about projects that our scholars completed within the general category of diabetes and chronic disease prevention and management. We had some wonderful projects, and just today to highlight those projects is one of our wonderful faculty advisors out of Arizona, Dr. Catherine Kenny, and I often call her Kathy. I hope that's okay with you today, Dr. Kenny. In any case, Dr. Kenny will be presenting these projects today on this webinar, and I want to just, again, thank you in advance for doing this great service today for us. Dr. Kenny, I'll just introduce you for a moment. Again, she is one of our faculty advisors there in Phoenix, Arizona. She has a number of titles, but certainly clinical associate professor and director of nursing practice and program director there at the College of Nursing and Innovation at the Arizona State University. Dr. Kenny was a faculty advisor for our students there working in the sites. And again, we really appreciate your service to us today and all summer long. I'll turn it over to you. If anybody has any questions, I would ask that you hold them. So you can certainly send a chat question to me. You will see a chat screen there if you have any trouble with the webinar. But otherwise, I believe that I'm going to turn this over to Dr. Kenny to get started. And again, thank you for being with us today. Dr. Kenny, all yours.
Okay. Thanks, Linda. Hopefully you can all hear me okay. I want to just express my thanks for being part of this wonderful experience to be a faculty advisor, and also for the privilege to be the moderator for these projects that have been done. Just sort of background information, as the faculty advisors, we spoke about how to be the best way to present this information. Our goal at some point, I believe, is to have the scholars present your work. As you know, which is a common theme in the projects as I discuss them, time is of the essence in this ability to complete the projects. And so, given those time constraints, we needed to summarize the projects for you, have the advisors do that. And I want to thank those of you who have sent me a PowerPoint. I haven't been able to figure out how to upload two documents at the same time. So I would just like to discuss and give you an overview of the projects that were done. And I see that some of you who completed the projects are online with us today, which is really great. So I think I'll just go ahead and begin discussing. And if you're online, when I finish with your project, perhaps you can interject some of your own reflections and direct me in a different direction if I haven't really understood what you're trying to present with your project. But overall, I'll tell you, the projects were very meaningful and the papers were very, very well written. So with that, let me start. And on your screen, you might see me looking away because my camera is in a different spot from my computer screen. So it's not that I don't want to be looking at you. But I'll start with an introduction. There were 9 projects that were sent to me for review. And of course, as you know, you were all working in community health centers. So there's some commonalities between all of these. Underserved population, chronic disease, including diabetes. There were 2 that dealt with diabetes and depression, and how the outcomes of self-management vary with having a comorbid condition of anxiety depression, which was very interesting. Also looking at psychosocial factors, especially with the population. Many of you presented demographics of your population that you were working with. Most of them were well below the poverty line. They had varying degrees of education, most of them less than high school education. Health literacy was an issue that was brought up by many of you. And as you reviewed your evidence and did the background and significance, you very well presented that the information is out there, guidelines are there, but delivery of information in a meaningful way is what's extremely important to change behaviors and outcomes for our patients. So with that said, let me just begin. So Bethany, I see that you're on the call, is that right? Can you hear or no?
Hi, back. I believe, although she might not have heard that, but I will, I believe she's unmuted, but I'm going to check on that here in a second. So.
Okay, all right. So, Bethany, hi. I see your name at least on the list that's a call. What I'm going to do in an organized fashion, because I'm a very visual person, and when I put things together, it helps me to look at them to kind of summarize. So I'm going to do just that for all of these projects. So Bethany Baker did a project in the Matthew Walker Comprehensive Health Center in Tennessee. The project name was Dialed Down Diabetes, and it was a web-based course. So this is a project that utilized technology, which is extremely important, but utilized technology to present health-related information to diabetics. The problem that she identified, and I often refer to this as internal evidence, this shows that you've done a system assessment. You know not only the national guidelines, literature, and research that's been done, and you're translating that into practice, but you also have done internal investigation of your setting at the community health center so that you know that this is a problem that this population or the providers really need to improve healthcare outcomes. So the problem identified was that there's a high rate of diabetes overall in Tennessee. This particular setting did have classes available, but there was low attendance. There was marketing of the program to the community so that although there was very good information available, the community members and the members of the community health center they weren't aware that this existed. And target population were African Americans and Latino women, and we know that the evidence shows that they both have high incidences of diabetes. The hypothesis was that better educating this population to the dangers of diabetes and the available resources, the students to the Dial Down Diabetes program would increase. The project was to educate and advertise to the people of the Nashville community of the disease of diabetes and the resources that were available to them. The project intervention was actually a 10 to 15 minute interactive course that was designed to be presented at the elementary reading level. The way interactive educational tool and presentation was designed and implemented, and with the goal to reach a diverse audience to improve understandings of diabetes through interaction and increased attendance at the Matthew Walker Dial Down Diabetes program. The program can be used as a model for other learning platforms, so other chronic diseases other than diabetes could certainly model this, and also be used to reach those that may not otherwise have access to healthcare education. This was done collaboratively with the providers at the Matthew Walker Health Center, and was accepted by the center and Vanderbilt providers to be and was approved to be added to their website with minor revisions such as lowering the reading level. And the revision that was in this, the conclusion of the project, that this format can be replicated for future educational programs. You need to always be cognizant of the target audience when designing educational information, and a project like this takes more time than anticipated, which probably most of you can relate to that these projects, not being familiar with your setting, having to do a system assessment and really look at the internal evidence to support a project actually took much of your time, so that you did not have as much time as you probably would have liked to have to implement this project. Sorry about that. I didn't move this page forward. Go. Beth, is there anything that you would like to add? And you can type it in if you'd like.
Can you hear me?
We can.
Yes, great.
Oh, okay, awesome. I'm so sorry. I was having a little bit of difficulty at first. I don't think anyone can hear me. But yeah, this was definitely a time-consuming project, and I think that if we did decide to do this using web-based, making a web-based course, is not to underestimate the once you're starting to wrap things up, and that's kind of the one thing that I just wanted to add. If someone did, everything went really well with it, but if someone did try to do this again, just to really plan for that ending time.
Oh, Kathy, for some reason the connection went out, so I'm back. Are you there?
Hope is here. I'm putting my video back on for just a minute. I don't know if you can hear me. I hope you can, Kathy.
Yes,
I just wanted to mention to everybody that I have unmuted every attendee so that our scholars can participate, but I would ask that each person on here individually on their own phones mute themselves and unmute yourselves whenever you would like to participate. That way we won't have a lot of background noise. So I have taken everybody off of the WEX mute system so we can all participate. And that's it. Thanks.
Thank you so much. Okay. So Bethany, are you there still?
But I'm not sure. Disconnected or something.
Okay. Anyone else on the call? Do you have any comments about this project? Any reflection that you'd like to share? Anything and see any typing. So I move on to Marianne Garcia, and I see that you're an attendee on the call as well. And sorry, Beth, I didn't have the name of your school, but Marianne Garcia is at the SUNY Downstate Medical College, and her project took place in the Community Medical Alliance Clinic at the Bell site, Northeast Community Clinic. Her mental health referral practices in diabetic management at Community Medical Alliance Clinic and the Northeast Community Clinic. And her focus for this was to look at depression and anxiety in relation to diabetes outcomes. So her background information included that depression and anxiety are two prevalent chronic conditions, and they're often seen in primary care. Often they're underdiagnosed and definitely undertreated. And compared to patients with diabetes alone, patients with depression and diabetes, I'm going to move the page along here. Patients with depression and diabetes have poor outcomes because their self-management, they have less self-management skills or self-management skills. Her target population was Hispanic Mexican Americans. So the purpose of her project was to identify referral practices of the providers at the community clinic in regard to patients with ICD-9 diagnosis of depression and or anxiety or not otherwise specified, and also to identify patients with a comorbid diagnosis of diabetes type 2. And they were identified, their management was evaluated through their last 3 recorded hemoglobin A1C values. So this is a retrospective chart review, and it was quite detailed. 70 charts were reviewed. Back here. So 75 charts were reviewed. You can see in age. With many of these, the age of the population is between 40 and 60, many times. So mean age was about 48 years old, 20% male, 72% female. Depression was found in about half of the study population. Anxiety was present in 21%, depression and anxiety in 29%, and diabetes type 2 in about a fourth of all of these patients. And then she looked at after she looked at the demographics and the incidence, she looked at the referral. And if you look at this, it's interesting that over 50% were referred for treatment of depression. 13% of these patients declined the service. 10% were referred for depression and anxiety, with, again, about 13% declining service. And 31% of patients with anxiety were referred, but over half, about a fourth of these patients really declined treatment as well. And you can also see that the average hemoglobin A1C value of this population was 8.1, which reflects on substandard control of their diabetes. She identified some of the study limitations, so this was a retrospective chart review, reviewed by a single reviewer since this was a project. The charts were handwritten, which sometimes can be a problem. And the thing that she commented on, that if she would have had more time, again, there were some time constraints, to follow up directly with patients who referred for mental health services to find out perhaps more information. Why did they go? What were some of the barriers to receiving mental health care? And also look at provider referral patterns to really evaluate if there were any gaps in the referrals for mental health treatment. Overall goal was really increase referrals for mental health to improve diabetes outcomes. You're on the call. Is there anything that you'd like to add? Any personal reflections?
Just to unmute your phone if you would like to participate in the session. So
I would invite any of you to participate because it's a good learning experience for all of us. And again, I think one of the things that we had spoken about as faculty advisors is that based on, my interpretation is based on your written paper, what you had submitted. So if the intent or my perception of what you were writing is accurate, please feel free to comment and share your actual experience because, again, this was very well done. Many of you presented charts and graphs of your findings, so please feel free. I see Marianne, your hand is up there. Is there anything that you'd like to type in? Well, maybe Marianne just jumped off. Oh, hand is raised. Okay, I'm going to move on. If at any point any of the attendees and scholars in particular are able to unmute your microphone and join the conversation, please feel free to join the conversation and interrupt me as I go on. Okay, the next scholar is Carolita Heritage, and I see that you're all on the call. Carolita from the University of Mississippi School of Medicine. Her project was a diabetes education project, and it was at Jackson Hines Comprehensive Health Center in Jackson, Mississippi. Her background information, again, shows that the incidence of type 2 diabetes is higher in Mississippi than the national average. Programs exist in this setting, but providers' time constraints do not always permit the time that's necessary to discuss diabetes education. So, of her project was to educate patients about type 2 diabetes, focus on health promotion, and this particular center did have a program called Diabetes Night where patients could attend to learn about nutrition, pathophysiology, causes of diabetes, and so her intervention to implement, she wrote the providers, compiled education resources for diabetes, nutrition, and educated patients in groups and individually. The other interesting thing was that she developed diabetes-friendly recipe handouts, and then she did a survey after she presented this information to patients. And so I'd like to share her some outcomes. So age, again, you can see it's a common age range, 41 to 60 years old. Over half of the patients were in this age group. 50% had 5 or more office visits per year, so health care consumption was up. 7% did not have a college degree. Over half lived below the poverty level. 6% of the patients that she actually interviewed had diabetes, but 64% had someone in their family with diabetes. Another interesting finding was that although 70% of these participants considered themselves informed about diabetes, only 38% of them, 38% did not identify correct risk factors for diabetes. The other interesting thing was that 76% of this population that participated stated they would read information about diabetes if it was at their provider's waiting room. 84% had never taken a diabetes class. So 72% expressed interest in attending a class. The reflections in this project was that Carolita was able to observe education classes and watch what the providers were currently able to present to these patients, and that helped her to develop some educational sessions as well as written handouts. The ways that she did both before and after her education served as providing internal evidence that this population had a need and they were very interested in education. And her other reflection was that she really learned a lot about the leadership aspects of community health centers, which is one of the goals for this primary care fellowship program. So, Carolita, are you on?
Yes, I'm on the call. Can you hear me?
Yes, excellent. Hi. Really nice job with your project. Would you like to add anything?
I'd just like to add that I felt this gave me a wonderful opportunity to learn how I should best present the information about diabetes to the population, because I am interested in staying here in Mississippi, and so having the survey, send out to the patients really helped me see what kind of population that I'll be dealing with here. And, having 64% of the patients have someone in their family with diabetes, they're going to help them as well. And so being able to give them out so they can take back to their family, and then being able to help the ones with diabetes one-on-one and in groups, it really helped me, form how I can do this even later on when I become a physician and now as a student.
Right. You know, I think one of the beauty of a program like this is that as scholars, you have the time to do the background, read evidence, and really translate that research into practice and start making an impact now, because you all really are the providers of the future. That we know with epidemic proportions of diabetes, heart disease, obesity, that we have to deliver our education and health promotion different than we do now. So I think it's really great. Did you feel like you had the background and information to develop the teaching aids that you did and the supplements, Carolita?
Yeah, it felt like the classes that I had taken already in medical school, and then also having access to the physicians that I could shadow and ask them questions between patients and things like that, I was able to compile the resources and develop things that the patients could understand and learn from.
Yeah. How much time did you actually spend on the project? I mean, it was probably a pretty quick timeline.
It was scattered throughout. I couldn't really put a exact time that I spent on it, but I mean, a day I would discuss either with the patients in the waiting area that I was surveying or with an individual patient in the patient room. I would discuss diabetes education with them. So it was just scattered throughout each day.
Mm-hmm. One thing that I would just overall say is that these projects are very meaningful and they were well thought out. But think about in your future work that you're doing, and if you come back to the program or you're working, as a student or you're doing other practicums, is think of a sustainability plan, because you had the time and you were supported to do this. How would they continue to deliver this high level of education if you weren't there? And there certainly are a lot of reasons why it can't happen right now. But as you go through your education, this is just the beginning of your interest, I hope, in improving education, improving patients' understanding, acknowledging the need for health literacy. But think about how you might sustain these projects as you move forward into a different role yourself. So I just throw that out as a comment. Anything else you'd like to add, Carolita?
Thank you.
Thank you so much. Okay, Marwa Ibrahim, let's see. I don't see if she's on unless she's one of those that are numbered.
Yeah, we do have a number of attendees who are not registered, but so we're sure who they are. They're mystery attendees, but we're happy they're here. So.
Okay, well, Marwa, if this is one of you, I'm going to present your project now. Marwa was a student at New York College of Osteopathic Medicine, and her project was self-management of patients with diabetes and comorbid depression. So again, it's interesting that we have a second project that really is looking at the effect that mental health has on health promotion and ability to manage chronic disease. She was done at St. John's Well Child and Family Center in Los Angeles, so we're across the country now in California. But it's also interesting to note that the same problems exist across the country in various geographical regions, very similar problems. So her background was patients with both diabetes and depression have been shown to have worse glycemic control. They have increased risk for cardiovascular complications, increased mortality rates, and higher healthcare costs. Diabetes self-management is key. Depressants are less likely to adhere to self-care regimens than non-depressed patients. The project was to learn about the perspectives of people living with diabetes and depression and identify barriers to self-care management. And as we see, looking at all of the projects that have been presented so far, education and self-management and patient involvement, the best research and evidence shows that is the best way to manage a chronic disease. The challenge, though, is to engage patients to do so. So her intervention was a 1 30-minute focus group and it was an interview with diabetic patients at the family center that had comorbid depression. She had 9 participants, and this is some of her outcomes. 9 participants, 8 female, 1 male, 8 Hispanic, 1 African American. And again, very similar, 53. Perceived cause of diabetes is family history and lifestyle, and this is the information she gained from having the focus group interview. Barriers to managing their diabetes, food, either inability to afford food, not knowing what to eat, stress from all different causes, including unemployment, family relationships, safety issues, support for self-care. So family support and diabetes education was considered positive in order for them to continue with and participating in self-care of their diabetes. And one of the other strong indicators for that seem to incentivize these patients to really start to participate in self-management is complications that they saw in family members or themselves. So, for example, blindness in the family, other complications related to diabetes. They identified resources that were needed. And I think this is really important. One of the things that we all need to think about, culture relevant, particular to nutrition counseling, but I think culturally relevant education to really help them embrace their cultural norms. If we try, and this is my own editorial, but if we try to change patients' behavior to meet something that is not congruent with their cultural, religious, or whatever they might be, their norms, it's not going to happen. So while healthcare providers may not think that the healthiest diets exist in some of these cultures, how do you work around it? How do you make them more healthy without disrespecting or taking away their cultural norms? Others that were identified by this focus group were financial resources for medications, and there were comments made, really a good qualitative review of what these focus groups said. But financial resources for medications, they talked about how the pharmacies that they were able to go to, so many of these were uninsured or underinsured, the pharmacies that they went to either ran out of their medications or the cost of the medications were so high that they could not afford them. Therefore, again, this is an editorial, in many practices, patients come back and don't fill their prescriptions and they're labeled as being non-compliant, which is probably true in the sense of the word. However, we have to look at the reasons for non-compliance and the barriers that are there. And they also identified that they needed increased mental health services. So I think the introspection and the presentation of their responses in this focus group, I think, were very revealing. Some of the patients that Marwa identified was that it was a small sample size. Of course, it was only 9. And because of this, we certainly can't generalize the results to a larger population. However, this does add to the body of knowledge that we already know that's out there. And one of her other reflections is that St. John's is on the right track for offering classes and support to the population of patients. Do you have any comments about this before I move on? I don't see that she's on the call unless she's not identified. But any other comments that anyone has? Okay. The next project is Crystal Lucelle, and I see that you're on the call. Hi, Crystal. I'm glad you're here. Crystal is a nursing student, graduate student at UCSF, and she was at the Adelante Community Health Center in Buckeye, Arizona, which is right outside of Phoenix. It's considered underserved and rural. And her project was to implement shared medical visits for patients with diabetes. Background information showed that there's a high incidence of diabetes in this clinic population. The majority of these patients are Spanish speaking. I'm also in Phoenix, and I was Crystal's faculty advisor. So we have a high population of Hispanics who are only, they're monolingual and they only speak Spanish, which can sometimes certainly impact delivery of information and education, which she found out. In her setting, time for education is limited during regular office visits, especially when an interpreter is needed. And most aid is there to provide interpretation. However, when providers are not Spanish speaking, you're interpreting and having your message relayed to the patient, having their message relayed back, and it does take up time that English-speaking or other Spanish-speaking providers would not have to lose that time to interpretation. Rather, they could be really directly educating and speaking with the patient. So she identified that. So her intervention, she identified Spanish-speaking patients, identified them, and invited them to attend an educational session that was held at the clinic. 20 participants were identified. Patients participated in a 90-minute workshop. And the workshop was actually, Crystal speaks Spanish. It was presented in Spanish. And she did this with posters, and she showed some of the examples of the posters in her paper, and they're very good. They were not overwhelming to patients. I think they looked, they're not high technology. However, for this population, I think it was probably comforting for them to be able to look at a poster and have Crystal speak to it. She presented the information on diet, exercise, type 2 diabetes, health promotion topics. The patients reported satisfaction with the class, and many reported never having received this level of detail about diabetes. Some of her reflection is that time is needed to plan and organize shared medical visits. Patient suggested weekly sessions, so something to consider for sustainability in this population would be perhaps every Wednesday at 2 o'clock there's a group meeting or session on diabetes, and here's what the topic is. Or perhaps you do one topic per week and then you repeat it monthly. Next to this clinic, there's also a WIC clinic, and one of Crystal's reflections was to include the staff related to available nutrition and therefore discuss healthy eating patterns with the food that was available to them. And so another reflection would be to obtain baseline data including weight and hemoglobin A1C and follow this over time so that you could compare the effectiveness of this education and look to see if perhaps some behavior changes were happening because of education. So do you want to share anything? I see you're on the call.
It's me here again. So Crystal, be sure to unmute your phone or your computer if you would like to participate. We'd love to have you on discussion. Thanks.
Well, Crystal, if you want to type something in, please feel free, or if you can unmute your microphone or join in, please do so. There is, many of you in your reading, especially looking at delivery of education, you may have come across some of the literature that talks about shared medical visits. And one of the challenges is to actually have staff available to conduct these medical visits. One of the good things about it is that they are reimbursable, and so something else to consider. And even if it's not in a community health setting, if you're in a private practice, it's also something to consider. The next scholar is Alexandra Palma. And I'm just checking to see if you're on the call. Yes, I see your name there, Alexandra. She's from Columbia University. She did a project at the Northeast Community Clinic in Los Angeles, and the title of her project was Psychosocial Factors Affecting Behavior Modification in Diabetic Patients. Information included factors like anxiety, stress, lack of social support, low education level, emotional personality type, correlated with lower glycemic control in patients with diabetes. So now here we have the third project that it's very interesting. As a reviewer of these projects, some of the background references were similar, but many of them were different, which goes to show you that there's a lot of information out there that corroborates this research that's been done. One of the points that she made is that lack of knowledge about hemoglobin A1C by this population was profound. Many of them did not know the importance of the hemoglobin A1C or did not understand the relevance to glycemic control. And she also had intended, the intention of her project was to really explore knowledge about hemoglobin A1C, but when she looked at her population, so again gathered internal evidence, that they didn't understand the hemoglobin A1C or the importance of it, so to try to educate them on that would probably not meet the needs. So rather, she took the stand looking at locus of control and how, if a patient felt in control of managing their diabetes, how did that affect their behavior. So it was a very, very interesting, I would say, and involved study. Shine locus of control, which were good. So it's a psychologic model which categorizes personal beliefs regarding one's control over outcomes. So again, the patient is in control. Her method was that she sampled patients with diabetes type 2, and they were all patients were given a survey over a week. Patients were included, and study completed a 6-question survey, which was given in Spanish. Take a look at the mean age in the 50s, and hemoglobin A1C was 8.5, which again shows that control could certainly be optimized. So what we found was very interesting. So she really summarized the findings of her study. She that more control of the diabetes was attributed to the provider than the patient in this population. So they put more emphasis on the external locus of control, which is their provider. And also very interesting. So in one of the groups where she found that the hemoglobin A1C was well controlled, the locus of control was higher. So meaning that those patients who believed that they were in control of their diabetes did control their diabetes. Some of her conclusions, the reflection was that low perception of control over one's diabetes in the context of the provider-patient relationship is associated with poor glycemic control. So a lot of emphasis was put on the provider as the person responsible for health maintenance, and we know in our country that that is one of the problems with Americans taking control over their own health outcomes. They believe that many times the provider is responsible for their health rather than them themselves. And she also reflected on what changes could be made in the way diabetic patients are treated to more perceived control. The quantitative data that she collected seemed to suggest that helping patients use more self-initiated behaviors to measure progress could be the first step in internalizing the control control loci. So this was very interesting, a qualitative study that really looked at patients' belief of over their own illness. Alexandra, can you add anything to this?
Linda, it looks like Alexandra is not on the call anymore, actually. She may have had to go back to her obligations. So in any case, but I'll let others that may have questions, obviously speak about them. And Kenny, it's Melinda again. I want to mention that we just got a question actually about one of the previous projects, though. So I don't know if you want to take that now or if you'd rather wait till the end.
Oh, Aisha. Hi, Aisha. Right here.
Well, I got a question from Natasha, as a matter of fact, about Crystal Lucell's project. She wants to know if you could describe what is a shared medical visit. That was Natasha's question.
Okay. So a medical visit is when patients with a similar diagnosis are brought together and actually receive counseling and education that in other settings they might receive individually. And how this is delivered varies between practices, but many times, especially in a community health center, patients are there for their provider visit, and so the provider does physical examination, looks at lab work, does the physiologic examination. We talk a little bit about some of the teaching, but the bulk of teaching is actually done in what's called a shared medical visit. So there could be anywhere from 2 to 3 to 5 or 6 participants that meet, and they're given education as a group rather than being individually educated by individual providers. Does that help?
And for Kenny, Melinda again, I don't know if you're able to see, I think you mentioned it a second ago that Aisha Alice asked a question. Okay, so.
Aisha, are you talking about Alexandra, her last one that we had spoke about? Okay. She did not give any specific suggestions, but she kind of overall made the observation that trying to do some smaller self-initiated teaching, such as monitoring their sugar, maybe keeping a journal, back results to the provider. So something small that gives them the responsibility to be part of what they're doing. So starting small rather than starting bigger for your behavior changes. I don't know if that answers your question. Okay. And a little note here. Right. Jim Sims was at Central Mississippi Health Center, and her project was interesting. It was called the Waiting Room Diabetes Project. Her, again, is going to sound familiar. Mississippi is ranked the least healthy state in the U.S. In this clinic are certified diabetes educators. So it was interesting. Out of all the projects, that's the only one that really focused on the providers and how they've been prepared to treat diabetes. This education project was developed to complement the current diabetes education. And Jane presented, she went into the waiting room, and while patients were waiting to see their provider, she gave them education. So some of the topics was just overall education about diabetes, heart health, foot care, exercise, obesity, and nutrition. And If there were a group of patients waiting, she did group education. If there was only one person waiting, then she did individual. She conducted pre and post surveys to try to evaluate how effective her intervention, her education was. Again, she did a very nice job of detailed presentation of all of her outcomes as far as what the answers were in the pre and post tests. All of the scores were improved, and these were not analyzed statistically, but they were just given kind of the raw scores. But all scores improved between the pre and post tests that evaluated learning. Based on the results, more education should be focused on nutrition because that's one of the areas where there was a high level of knowledge to begin with, even though it improved. So on that, she thought that there should be more education focused on nutrition, overall diabetes, and difference between type 1 and type 2 diabetes because there was misperception about that, and also how to care for those who are living with diabetes. So a lot of family members, as we heard in one of the previous presentations, that many family members take care of other family members with diabetes, and how physical activity helps those with diabetes. And base those on the outcomes from her pre and post survey. So she provided some suggestions for survey revision, so asking perhaps questions a little more clear, and really rather than asking sort of superficial questions about, you rate your level of knowledge about, maybe ask some more specific questions. The reflection that education is actually primary prevention and improves awareness of diabetes. And one of the other benefits is that if you're working in a busy clinic and that providers are running late, this can actually improve patient satisfaction as well as outcomes because it may decrease the perceived waiting time. So, Jillian, are you on? Let's see.
I don't see her on our attendance list, although she could be one of those unidentified callers. But
does anyone else have any comments about this? One of my personal observations was that I think this is actually an innovative way to patients that are sitting there that perhaps watching TV or flipping through a magazine could be time that they're there anyway that you could really capitalize on. The follow-up question is, are you going to sustain this program when we don't have a scholar there that's providing the education? I think taking the waiting room initiative is interesting. I think it's similar to kind of the principle of shared office visits, that you're putting education outside the actual provider visit. Okay, let's move on to Amanda Smithers from SIS University. She completed her project at Central Mississippi Health Services. The project was improving approaches to patient education, improving tracking of patient outcomes. So this brings in the part of technology that many providers and practices are struggling with, is that we're using electronic medical records in an efficient manner, so that we're using them more as a repository for information rather than a tool that we can actually collect outcomes. And so her background information showed that limited health literacy is associated with poorer health outcomes and also increases healthcare costs. So we've got low socioeconomic populations. We've looked at lower education. And we're really talking about health literacy and how important it is to be able to present information at a level that our patients understand. So she gave some background. 72% of the patients of this population live below poverty level. 38% is a high school dropout rate in this area. And from a provider perspective, the electronic medical record system was outdated, not used effectively. In fact, she commented in her paper that many just put information, values, lab values, maybe they did that, but really did not use the EMR comprehensively. So the purpose of her project was to assist in improving approaches to patient education, and it was twofold because she also wanted to look at improving tracking of patient outcomes. And now we really need to report improved health outcomes, one of our initiatives, especially a community health center, federally funded, want to look at outcomes to our care. And with an effective electronic medical record system, it's very hard to collect this information manually. So what she did is she looked at what education information was available to the providers. And she went into her electronic medical record system, and I don't remember if she updated them, but I believe she did. So she looked at them, updated, and then printed out the copies from the electronic medical record and put them in a binder so that they were easily accessible to the providers, which in turn providers could share with the patients. She also developed CPT codes, which were printed on pocket cards for the providers, so that when they documented, they actually document according to CPT code, and then that way outcomes could be measured. At least it was a beginning where outcomes could be measured. The interesting thing about her project was that she engaged a committee that already existed. It was a Quality Improvement, Quality Insurance Committee. So she really worked within the system and the support she had to help her base her project on a real need, but also to have somebody oversee what she was doing to make sure that it was something that was going to be useful in meeting their documentation of their outcomes. One of the things, though, in her reflection was that she's all ready to start this project. However, like we know, we're going to be audited. There's a HRSA site visit, which actually took precedence over her gathering this information and working through the system. And so it really only left her a very short time to implement this project. I believe it was only a week. That her reflection was that she needed to focus on health literacy of the population served. And I think this is a really poignant point for all of us, that we speak this language, and even though we believe we are presenting it at a level of the literacy of our population, sometimes 5th grade, 4th grade, even 3rd grade level might not be meaningful. And to go back to Crystal Lucell's project, she already presented the information very basic to the population that she was teaching, and I think that was a plus for that project as well. She capitalized on the strong provider-patient relationships. She also said that many of these patients had been seeing their provider for 20, 30 to 40 years, so they had very, very strong provider-patient relationships. That in turn can incentivize patients' behavioral changes. They trust you as a provider, giving them valid, understand information. That's one point. The other point is, if you have a relationship with your patients, some of you have found this, those patients do not want to disappoint you. They want to do what you believe is in their best interest. That also connects with the project on locus of control. So I hope you're seeing that some of the ties between projects, even though we're done in different settings with different populations in different parts of the country, there's so many commonalities that we can learn from it. She also identified that this particular clinic could explore a medium for education. So in-person classes, one of the providers did a public radio show each week that could focus on certain aspects of education. And so if she were going to continue this work, she did identify various methods of providing education that would be cost-effective and reach a large audience, and also really focus on provider documentation of outcomes. Would you share any comments about this particular project?
We have a chat from Bethany Baker. So, Dr. Kenny, if you can look at that as well. Your pull-down menu, are you able to see that? If not, I can read it to you.
Let's see. I may be able to. Let me pull it.
Thank you, Bethany, for providing some feedback for us.
Okay, in response to your earlier question, perhaps one way to continue education after scholars have left would be to implement a program like the online course I created. Yes. It would require having some computer stations, but perhaps that could be something donated or covered by a grant. That is an excellent point. There are practices now who put sort of a kiosk in meeting rooms. Several of my Doctor of Nursing practice students in education in their own practice by a kiosk or by having an iPad that was well attached so that it didn't walk away. And practice does podcasts so that while patients are sitting, they can put on a headphone and listen. But that is an excellent suggestion. I appreciate that. Bethany, do you find that there was good reception to the online? Did you have enough time to really be able to evaluate how impactful it was? I see a question, Bethany. How successful? In the one student who implemented it, it was his own private clinic that he owned, and it was very successful. Everything he measured was statistical significance. I don't believe he collected long-term outcomes, though, to see if it decreased really, what the impact was to decrease the incidence of HIV among his population. The other practice that did the podcast with the phones was a practice clinic, and the thing that they did not do is really measure knowledge or behavior change. They measured more satisfaction and asked some very basic questions, so it was a very small study. And Bethany, let's see, ended up needing more time. Yeah, I know. It's a thing to really look at the project and implement it. I have to say I'm so proud of all of you. In such a short time frame, you wrote beautiful background and significance. You had to support what you're doing, and you implemented a project in a site that you were not familiar with. So all of the things that you need for successful implementation of a project, you were able to accomplish. So I give you recognize all the great work that you did. There's one more project that was put in this group, and it's a different topic, but I think since we reviewed it, it's interesting conversation. Looking at avoidable readmissions of patients in a community health setting, and this is one of the challenges that CMS, most Medicaid programs are really looking at is how do we decrease the costs by decreasing hospital readmissions. So it's not directly related to an educational project or a data collection project like the other ones. I think we're talking about, this was done by Rocio Solano Padilla, and she is at Towson Boston University. She did a project in Los Angeles at Ultimate Clinic. She used a program called PACE, which is a program all-inclusive care of the elderly. And what she did was look at performance on post-discharge primary care evaluation. What the background has told us is that reduction of avoidable hospital readmissions is a local and national challenge. Nationally, readmission rates are right around 24 to 25%, which is a quarter of all people who are discharged from the hospital are readmitted within 30 days. Evidence supports that patients who have seen a primary care provider for post-hospital follow-up are less likely to be readmitted. And research has shown that the magic number is about 72 hours. That's a suggested time frame for follow-up. Aim was to examine the post-discharge time primary care visits in a population of patients, taking into account whether or not the emergency department diagnosis was discussed and the resultant effects on readmission rates, what the effects were for patients. So our goals were to determine the performance for a 72-hour window between discharge and primary care provider visit, determine hospital diagnosis, for which the patient followed up with the primary care provider, assess clinical data from this particular practice in relation to current national data, and participate in the clinic's vision of leading community health services by contributing to the continued evaluation of performance set by PACE. So we really went to their mission and vision statement that included this. It was a retrospective randomized chart review, included 40 patients and 57 admissions. What we found was that less than half of these patients were seen within 72 hours. The day for PCP follow-up was about 4 days was median, but average was 5 days. So that's over the 3-day recommendation. Looked at some of the reasons and reflected on that. So she found that readmissions were 24%, which is comparable to the national average. She then looked at the reasons for delay in follow-up with the primary provider. Patient compliance, so the patient was told to follow up, the patient may or may not have had a scheduled appointment, or the patient didn't show up. The primary provider, and this is key when we look at communication between levels of care, PCP is unaware of the patient being in the hospital, so there was a delay in the discharge summary from the hospital physician to the primary care provider. And patients don't always call their primary provider to let them know they've been in the hospital. She looked at interventions to improve follow-up appointment times, noted that there were some interventions in place, such as caseworkers would call these patients. They were notified from the hospital that their clinic patients were discharged. They would get a telephone call. Limitations to her study was that it was a small sample size. It was a retrospective review, and time limitations, just like all of you had with your projects. And she was unfamiliar with their electronic medical records, so navigating through the record to find the information that she needed was a little bit tedious. I think her small observational and descriptive study actually is very similar to what we find both in large practices and small private practices, that the communication between the acute level of care and community level care certainly needs to be something to be worked on. So that's not exactly fitting in with the rest, but I thought it was something that certainly we'd all look at and discuss a little bit. Let me I provided some editorial comments and summary as we went through each project, but I hope for those of you attending, it was interesting for you to see the diversity of settings as far as geographical location, but common demographics of the patients that we serve in community health centers. So hope that it was revealing for you to see the disparity in health care and the underserved populations that we see in community health centers. And these are the patients who actually have access to community health. We also have a large population in our country of patients who do not have access to health care. And when they have the access and the ability, they don't have the opportunity. The significance, as I mentioned before, for all of these projects was very solid, and you did a really nice job sorting why this is a national problem, as well as why is it a local problem in the region, as well as what did the population in your community health center where you were working, what did really need. Also showed your ability to collaborate with providers to help them meet the needs of their patient population. So as we talk about sustainability, you have left that practice, but you certainly have not taken the impact or your ideas and taken away from the providers that are there now. So as also just some of my personal perspective in being a faculty advisor, in speaking to the healthcare center here in Arizona, the project was well received. The providers are anxious to have scholars back again. They believe that this type of a program will certainly help to improve patient care outcomes by bringing new insights, new ideas, new innovations into the way they deliver care. And it's also interesting to me how most of these projects really focus on the educational aspect of improving patient outcomes and the impact that can have. That is pretty much my story and reflection. I certainly would love to entertain any questions or comments from any of you, either verbally or if you want to get on chat and write anything, that would be great as well. Let me just maybe throw a couple of questions. Do you think this format of presenting the project so that you could see the diverse kind of settings, perhaps the geographical settings and the commonalities between patient population, was this helpful for you with what your goals were in this primary care leadership program?
I said a comment there from Bethany, who says that this has been a wonderful experience, and it seems like there were some very well thought out projects, which I have to agree with what she says.
Oh, I think so too. I'm very, very impressed. Very impressed. And let's see, a comment, was a helpful way to present the project. I think it would have, something we'll consider, I think, in the future is that it really would have been beneficial for you all to be able to present your own project because you've done the work, you know it, and you certainly would have a much better insight and reflection. Although I think you could see that you all expressed yourselves very well through your writing so that I could kind of put together a summary, fairly easily, So I had a very well-written papers, and by the way, many of these are publishable. So if you have a mentor either at your school or interested in publishing, I would be happy to serve as a second editor or a co-author if you would like, because these are definitely publishable papers. The other thing to think about is presenting these for medical students are, the academic family practitioners. I think there are a number of medical organizations, the ACGME, conferences, where you can actually present your work as a medical student. This would be absolutely a great way to present. And for those of you that are nurses, there are nursing conferences that would love a poster or podium presentation to send in an abstract, and I know a couple of PAs, I'm sure your organizations really, there's value on the work that you've done, and really the next step is to disseminate your information. Let's see. Oh, Romeo, hi. Maybe if new scholars start up where Tiger had left, it could ameliorate the time issue. Yes, I agree with you, and we have actually had some discussion among the faculty advisors. Now we're more familiar with the community centers where we may be advising students. We could do some upfront work perhaps and have topics already identified that students could pick if they have an interest, but I agree with you.
Sasha has a question down there. Do you see that, Kenny?
Let's see.
Thank you for presenting the projects. I was wondering how common are electronics being used in patient education, primarily in an outpatient setting?
Oh, you mean electronic technology to present education? Well, it really depends on what kind of resources the practice has. It will, I think, depends on the technology interest of providers or the people that work in the clinic. So, for example, there are many practices now that have electronic medical records, that have patient portals, that you can go into the office and sit down and type in electronically your information, and it goes into your medical records. In one of those same settings, you can access patient information that is on their some of their mainframe drives. I would say it's the majority, but there are many now that are looking at using technology. In this population and community health centers, you know, there's some challenges because patients may or may not have access to technology once they leave your office. I mean, would be is if they could log on or take home a DVD or have access to this information whenever they wanted it, or they could look at it with someone else, perhaps if they had a low literacy level, they could with other family members or something like that. But you really have to keep in mind the resources that both the practice, the setting, and the patients have. But I think in the next few years, I believe that there'll be apps that some of you will be involved in developing. Will go on to, you know, smartphones, iPads. They're already there, but them are at a higher literacy level than what our patients might need. I'm glad you brought that up. You too, right? I meant to include that and I forgot. But she used the website, and you can probably all read that too. But you can create educational programs for free, and you can also have audio and have it translated. That is a really good resource. Thank you so much for bringing that up.
Actually, copy that and paste it to, that was just sent to the panelists, but I'm going to send that to everybody. So.
Okay, great. Bethany also commented that there are ways to give patient education, and the main cost would just be the computer or the kiosk. Yes, absolutely. I think that's something as you move forward and get into practice, really look at how you can optimize technology, because as you know, provider time is money, and to sustain something has to be cost effective. Needs reimbursable, at least the way that things are being offered now. And many of the doctoral programs, at least in nursing, include a communication and technology course in healthcare. So I think we'll see a lot of innovative ways to deliver electronic information. there's also, while we're speaking about technology, in many hospitals, they have a system whereby patients can turn on their television and they can receive health information that is valid, it's reliable, it's from a reliable and reputable source. They're commercial networks. Some of them are really costly. Others have a closed circuit television where nurse educators, their researchers, and their physicians actually develop in post-education modules. So I think a great project would be to bridge acute care with primary care or community care, where the hospital is actually teaching, and how can we in the outpatient arena continue with that education? Because I think what happens now, they get a whole bunch of information when they're hospital. They leave it a whole folder and binder of information. Then they look at it again. They're so anxious to go home, or they don't feel good, or they're afraid, or this information perhaps they didn't want to hear. They're not going to remember it. So if we were privy to what was being taught in the hospital and we could access that electronically in the outpatient arena, I think we certainly could bridge that knowledge gap and continue the teaching that was started there. That Bethany made was to optimize on the time the patient spends in the center. It's important for the up-and-coming primary care providers to use technology. I think, Kate, yeah, you're right. And especially if the Academy of Family Practice Physicians, the AMA, the American Academy of Nurse Practitioners, we've all identified that primary care is a very valuable resource, and that we really have to think of good ways to provide primary care, the physiologic aspect of primary care, but also the education component. And when time is short, the education is kind of what gets, to the side. So I'm curious at what you think about the providers who all were certified diabetic educators. Had any of you ever worked in a setting where that was the case? I thought that was a very interesting way to sort of have the basis for diabetes management. It comes up, but I don't see anything else coming with it.
Kathy, it's Martha again. I think everybody is unmuted on this end and can definitely participate if they want to, but they need to unmute their phones or computers. So, and they can also text, right, into the chat box. But in any case, we will be doing that.
Yeah, and we're coming to almost an hour and a half already that we've been.
Yes, we're pushing our time envelope in any case. So.
Yeah. I would just like to say thank you all very much for the hard work that you've done, and thank you for the privilege to be the moderator today and to be able to really look at all the good work that you've done on behalf of our patients to improve our healthcare outcomes. I think it's absolutely wonderful, very, very impressive.
Same way, and it's really been intentional to read these projects and to, from afar, to pick up on all the enthusiasm from the scholars. So we're quite grateful for that on our end over here. And thank you, Kenny, for being so enthusiastic about being a facilitator today and a presenter, and for gathering all this information in such a great format. So I appreciate that very much. So.
You're welcome, and I hope it was meaningful, and I thank all of you for hanging on the line and listening to me go on.
Thank you. And again, this will be recorded, and I will send out an email to everybody with the recording link, so if you want to come back and revisit some of the information that was presented today, you can do that at any time. And, of course, you can email us here at the PCLP offices anytime as well. So thank you again. I will end the webinar, and I hope everyone has a terrific afternoon/evening, depending on where you are right now.
Thank you very much. Take care.
All right.